not be opacifying the pancreatic duct because we are worried about potential acidorization and pancreatitis. But as opposed to that, if you have actually now a guide wire insertion, the risk is significantly higher. So please be careful for those who are solely relying on guide wire passage. And a guide wire, just saying only a guide wire passed once is not sufficient. And these are all the various risk factors. And if you look at it, the guide wire passage has an odds ratio of 2.77, almost as high as pancreatic sphincterotomy here. So one has to be careful. This is a very nice guideline that was published by the ESG in endoscopy. How about pancreatic stents? So the idea of putting a pancreatic stent is that you minimize the risk of the periampullary edema. You allow the drainage of pancreatic secretions, thereby you minimize the risk. And the indications that we know where it works are after biliary and endoscopic sphincterotomy based on Paul Ternaski's study, there is a significant risk reduction. So also after a difficult cannulation and after a pre-cut papillotomy. This is a retrospective study looking at pancreatitis after ampulectomy, and there has been a significant risk, about from 33% in those who did not have stent to almost 0% in those who've had stents after an ampulectomy. So the procedure-related risk factors are established well, and I think placement of a pancreatic duct stent here definitely would minimize your risk of pancreatitis. And here you can see in this picture how nicely the pancreatic secretions are drained and minimizing the risk. So how about PD stent after a guide wire passage? And here you can see that there is a guide wire in the pancreatic duct, guide wire in the bile duct. And when the guide wire goes deep inside placement of a stent, if you do not place a stent, the risk of posterior CP pancreatitis is about 23%, drops to less than 3% when you have a stent placed. So when you get a guide wire into the PD, especially with a difficult ampullary anatomy or papilla, there is nothing wrong with it. Leave the wire and cannulate alongside into the bile duct, but make sure you actually place a stent in the PD so that you minimize the risk of pancreatitis. So use the pancreatic duct, but do not misuse it. Pancreatic stent after all ERCPs, again, it shows that there is a significant risk, but that does not mean that we should be trying to go and spend an extra 20 minutes cannulating, trying to cause more trauma to the papilla. So you have to be careful. These are some of the meta-analysis that actually show that stenting favors reduction in post-ERCP pancreatitis. Again, this is another meta-analysis that is done that that favors stenting in reduction of post-ERCP pancreatitis. So pancreatic stenting does reduce pancreatitis. So is it effective in all cases? But I think it is effective, but instead of causing more trauma and damage, I think it is effective in high-risk cases. Which stent would we choose? What is optimal? We do not know whether it's a long stent, short stent, whether a no flange stent, single flange stent. What I do believe is that we should not oversize the stent. So you should not be using large stents, 5 French stents, 7 French stents, or 10 French stents in a small, normal looking duct. So try to use a 3 to 4 French stent. And if you use a 5 French stent, a short stent without an internal flange probably is optimal. Though there are data that suggest that even a short-term placement of a stent can cause pancreatic duct stricture. So be careful when you choose the stent. Stenting the difficult pancreatic duct is hard, especially if you have an Ansel loop in the head of the pancreas. So you need to be able to place small guide wires and place small stents. There is a significant risk of trying and failing. So if you cannot readily get into the PD, I don't think you should be trying to traumatize the papilla and try to get a stent, because when you try and fail, the risk of pancreatitis is greater than 50% or more. And should pancreatic duct stents be the standard of practice? I think for all of us who do ERCPs, you should be comfortable with the idea of placing a wire in the pancreatic duct and placement of a stent, because you never know which case turns out difficult and where you need to stent. Last but not the least, as we are all doing, using NSAIDs, are NSAIDs just adequate or to replace the PD stents? So the story of NSAIDs is the most recent story in reduction of post-ERCP pancreatitis. This is the landmark paper that was published in New England Journal almost a decade ago. I think it shows that this is the placebo group, this is the rectal indomethacin group. There is a significant reduction in pancreatitis after administration of rectal indomethacin. Again, it's just not reduction in the incidence of pancreatitis, but also the severity of pancreatitis is minimized. The adverse events is not statistically significant, though there is some bleeding. The bleeding risk is similar compared to placebo and indomethacin, and no concern for renal failure. So rectal indomethacin can be administered. However, should we go ahead and start giving rectal indomethacin in every patient that you do ERCP? This is a study that looked at administration of rectal indomethacin in consecutive patients, and here it does not show any reduction in pancreatitis. So for high-risk patients, yes, there seems to be a benefit. Again, this is a study that was looking at NSAID use for prevention of post-ERCP pancreatitis. It's an updated meta-analysis of controlled trials, and it shows a single dose of rectal NSAIDs is effective in preventing post-ERCP pancreatitis, both in high-risk and unselected patients, regardless of the timing, whether you give it before or during the procedure or after the procedure, or whichever is available, either rectal diclofenac or indomethacin. So this is another meta-analysis that was published recently that looked at prophylactic rectal indomethacin in post-ERCP pancreatitis in general patients. It seems to be ineffective, but seems to be useful in high-risk patients. So recently, we published a study as part of this group with the Indiana, looking at, we know that there is a benefit in giving 100 milligrams of rectal indomethacin, and we are all, as human beings, we always are saying, well, if something works, twice as much should be even better, right? So we thought, why don't we do a dose escalation? So we did a rectal indomethacin dose escalation for prevention of post-ERCP pancreatitis, or the RIDE trial. And we randomized patients to either 200 milligrams or 100 milligrams, which is the standard dose. And there is no advantage of giving a higher dose. And the risk of post-ERCP pancreatitis is still high in the high risk group. So just giving rectal indomethacin and hoping that nothing will happen is not a good strategy. So routine pre-procedural rectal indomethacin to prevent ERCP. Again, it's a single-blinded randomized controlled trial. It shows that it does favor routine administration. So we have somewhat conflicting data whether we should give it to all ERCPs or just high risk. And I think at this time, we should probably just limit it to administration of rectal indomethacin in any person that you feel is a high risk. So you might start off with a low risk patient for your pre-procedure, but whatever procedurally, whatever you're doing might put the patient at higher risk. So you can still administer rectal indomethacin during or after the procedure. And I think standard dose, which is 100 milligrams of rectal indomethacin, is efficacious. There is no role for administration of a higher dose. And if you can, you're better off giving it before the procedure. So again, I want you to remember that if those of the patients who are still getting NSAIDs just as a sole prophylaxis have a 6 to 15% risk, based on the data that are available. And are they about to replace the PD stents completely? Should we be getting rid of all the pancreatic duct stents? The answer is probably not yet. So Venkat Akshintala from India actually looked at a network meta-analysis, and he thought that use of topical epinephrine and rectal NSAIDs are most efficacious agents in prevention of post-ERCP pancreatitis. Subsequently, the Johns Hopkins group has collaborated with several of the practices in India, and Some of you have participated in these studies, and they've done a large study that looked at topical epinephrine spray along with rectal indomethacin, and actually it did not reduce the incidence of posterior recipient pancreatitis compared to rectal indomethacin alone in high-risk patients. So the story of rectal indomethacin is that it probably does not work, and maybe, in fact, it actually increases your risk of pancreatitis. So pharmacological prophylaxis alone probably is not adequate to prevent post-ERCP pancreatitis. How about fluids? I started off with a small pilot study that looked at 8 hours of fluid administration post-procedure, standard fluids in 23 patients. And it showed that the post-ERCP pancreatitis, when you actually give more fluids, is almost zero compared to 17% in the standard group. So multiple studies were performed, again, in this double-blind randomized controlled study, where if you give 3 ml per kilogram per hour for 8 hours versus with a 10 ml bolus, compared to 1.5 milliliters per kilogram, the aggressive IV hydration group had a significantly lower risk of post-ERCP pancreatitis. Again, this is a meta-analysis that looked at it, that aggressive hydration reduces the overall incidence of post-ERCP pancreatitis. So most studies showed benefit in post-procedure hydration, at least for 8 hours. It is probably not feasible for majority practice. You do the procedure, you send the patient home in an hour or two. So keeping the patient for about 8 hours and administering the fluids might or might not be feasible. In our practice, we do give fluids widely open prior to the procedure, during the procedure, and immediately after, so that at least you hydrate the patient well enough. But again, studies have shown that benefit is there if you actually administer it for 8 hours. So what we do not know is the efficacy of brief hydration, and probably in time we would have data for this. So in summary, we all know that post-ERCP pancreatitis can be divided into patient-related risk factors, procedure-related risk factors, use of pancreatic stents, pharmacology, and use of fluids. So you have to be very careful in which patients you're selecting to do the procedure, and you should do them only when it is indicated, and only indicated patients should get the procedures done. Procedural risk factors should be evaluated and, if possible, intervened appropriately, either by placement of stents, use of drugs, or hydration. And pancreatic stents, when used, have to be done carefully, choosing the right size stent for a brief period. And pharmacology, right now we have data that administration of NSAIDs in high-risk groups is efficacious, not in all comers, and just a standard dose alone seems to be enough. We do have data that 8-hour administration of fluids, especially lactated ringers, is beneficial. We do not know the efficacy of short-term aggressive hydration. And I think instead of just choosing one, two, or others, I think a combined approach is probably beneficial based on your patient needs and the procedure needs. So do not dogmatically adhere to a single approach. Thank you for your attention.
Yeah, excellent presentation by Dr. Nalini Gowda. Short, sweet, and to the point. And it had said that you have to choose your patient very selectively, give them the best available treatment, uh, try to put stent whenever possible, but do not overtry, rather than, because sometimes even putting a stent in pancreatic duct inadvertently can cause pancreatitis. Again, giving NSAID just before the procedure helps, and the IV fluid before and after also helps. So, very good message we got, and just to prevent the pancreatitis. But you have to choose the patient very selectively, that those who with high risk, you have to be very careful. So I think we should start the another complication which is very deadly complication if not dealt with proper treatment is GI bleeding post pancreatitis. So we can start the next lecture.
Good evening, one and all. I am Dr. Avinash. I am an associate professor in the Department of Gastroenterology at MS Ramaya Medical College and Hospitals, Bengaluru. So it is indeed my pleasure to present to you this lecture on post-ERCP bleeding. The next 20 minutes of my talk, so we are going to deal with like what is the definition of post-ERCP bleeding. So what are the risk factors, that is patient-wise and procedure-wise, and how are we going to manage the post-ERCP bleeding. So the definition is like any upper GI bleed, it is similar hematemesis and or melena. But most important thing that they have mentioned is hemoglobin drop of more than 2 grams per deciliter. It can be immediate, that is during the time of procedure. Majority of them will be self-limited, or it can be delayed, so which can be hours after the ERCP, or it can extend up to 10 days post-procedure. The 2007 meta-analysis by Todd Barron et al. So has mentioned an overall bleeding rate of 1.3%, of which 71% were moderate and 29% were severe, with an overall mortality rate of 0.05%. So majority of my slides are from ESG guidelines that got published in Endoscopy 2020. So like the incidence and the mortality rates were similar. So, but the thing is like they have defined what is the severity. When we say mild, so it is either of the following, that is abortion, like that is stopping of the procedure, like bleeding which necessitates stopping of the procedure, or which causes an unplanned admission for less than 4 nights. And in severe, there is an unplanned admission which is more than 10 nights, needing an ICU admission for a night, requiring surgery and a permanent disability. Moderate will be somewhere in between, that is 4 to 10 nights with an ICU admission. But whenever we say a repeat endoscopy is needed for a rebleed, or an intervention radiology procedure is needed, or there is some intervention that is needed for integument injuries, that is something has happened and we need to do something, so that will be like considered as moderate in the severity. So we come to the risk factors, that is the patient risk factors. So before we take up the procedure, we always divide it into pre-procedure, intra-procedure, and a post-procedure. The pre-procedure are the patient risk factors. We categorize the patient as a low risk or a high risk. Low risk patients are all who are having ischemic heart disease without coronary, that is obstructive coronary artery disease. People who tend to have either cerebrovascular or a peripheral vascular disease, atrial fibrillation without concomitant valvular disease, a prosthetic metal aortic valve. So these are all comprised of low risk patient risk factors for a post ERCP bleed. When we say high risk, that is an obstructive coronary artery disease with stent, prosthetic metal mitral valve, and atrial fibrillation with mitral stenosis. These are all the patients who are having high risk or whom we consider as high risk patients. Coming to the drug, majority of these patients are cardiac or a neurology patients. We should have a consultation liaison with the cardiologist or a neurologist, because when to stop the drug, like because risk stratification from their side also we need to take it into consideration. And when do we restart the drug, same drug after the procedure? Majority of the time, aspirin single drug we are going to continue during the procedure, unless or until it is a case of ampulectomy where we may have to consider stopping aspirin for at least 5 days time. Clopidogrel, definitely it has to be stopped 5 days, but again it depends upon whether we can continue it based on the procedure risk. Warfarin we may have to stop. We may have to wait till INR is less than 1.5. So after 2 days after stopping warfarin, we may have to overlap with low molecular weight heparin. Nowadays, more and more patients are on directly acting oral anticoagulants. So we may have to stop them for more than 48 hours. And if at all a person has got renal failure, which will decrease the drug clearance, we may have to stop them for 72 hours. To summarize the risk factors, so one is the anticoagulant intake. A patient who has a platelet count which is less than 50,000, it can happen in cholangitis indications. At that time, we may think about decompressing the drug, not decompressing the duct, rather than doing a definitive procedure. Patient who tend to have a bleeding diathesis, either in the form of cirrhosis, or a patient who is having end-stage renal disease requiring dialysis. During the procedure, whenever we tend to have intra-procedural bleeding, and there is a low volume of the endoscopist, like we do once in a while ERCP, there can be higher chance of post ERCP bleeding. Coming to the intra procedure, that is during the procedure, we again categorize the risk factors into low risk or a high risk. Low risk are the ones where we stent the bile duct without doing a sphincterotomy, or we just do a cholangioscopy. So these two comprise of low risk procedures. High risk procedure is whenever we tend to combine ERCP with sphincterotomy or sphincteroplasty, or we tend to do an ampulectomy for an ampullary adenoma. So, like these are all high risk procedures. Intra procedure, the most important thing that we tend to have, that we tend to do is a biliary sphincterotomy. So where we tend to, like, this is a like a large stone at the ampulla, and once we cut, there is a pus that is flowing, so predominantly cholangitis. Or we tend to do whenever we are doing a pre-cut sphincterotomy, at that time also it can bleed from the apex of the cut. So the most common high risk scenario is for the biliary sphincterotomy. So it should be avoided whenever we think about doing only a biliary stenting. If at all we do a day's procedure, that is dilatation assisted stone extraction. So at that time also we need to keep a concern on what is happening at the apex of the sphincterotomy. So how much is the length of the cut, that we should always remember. Like the safety of the cut should be like just up to the level of the duodenal fold above the sphincter. Concomitant chronic liver disease, endoscopic appearance experience, that is less than 200 procedures per year. Association of pancreatic sphincterotomy, so we might be doing cut twice, as well as whenever the center volume is more than 200 procedures per year. So because the bleed rate is per 100, so whenever the procedure numbers increase, definitely we tend to see couple of cases which tend to bleed. That should not cause much of a problem. So coming to the little tips on the endoscopic sphincterotomy. So that is, in the incision, it's always better to have an endocut, so which tend to have a blended between cut and coagulation. It's always better to have a standard wire, that is a wire within the bile duct. And nowadays we tend to use more of Olympus Wire D3. So we need to keep the affected 2 and a forced coag of 40 to 60 watts. The length of the cut is usually 5 to 10 millimeters. Generally, we tend to cut up to a 5 to 1 centimeter, 5 millimeter to 1 centimeter, depending upon the papillary morphology as well as the bile duct diameter distally and the stone diameter. So three things, like what is happening at the papilla. So proximal to that, what is happening in the distal bile duct, and what is the endotherapy that we are trying to do. So papilla should always be incised at 10 or 11 o'clock position. So like at the time, there is only 10% of all the papillary arteries are there. So the bleed chances are much lesser. So whenever the cut direction is in that area. So either it is a combination of the sphincterotome bowing, the right torque on the scope, as well as on the big wheel on the scope. It's always important that we finish the cut, even though there is a little bit of bleed. So whenever we cut, bleed is going to happen. It's always better that we finish off the cut. Otherwise, like if it is only part of the cut, the vessel will recoil. So once we finish the cut, the vessel gets cut through and through. At that time, the vessel recoiling will happen. The bleed control rate will be much better. It's always better to avoid zipper cut, that is excessive bowing on the sphincterotome, as well as intermittent cutting or incomplete cutting. Sometimes we tend to use the pre-cut sphincterotomy top down as well as bottom up. Then we tend to lose the anatomy, and we don't know where the biliary or the pancreatic orifice is going to come. So the trick in pre-cut sphincterotomy is never lose on the anatomy. Even though we cut 2 times, pre-cut 2 times, like it's always better to keep the anatomy in place, such that 48 hours later, whenever we go in, definitely it would have much opened up, and we would be able to identify the biliary orifice and the pancreatic orifice much better. Water jet comes in very handy. So whenever we tend to have a high volume water jet, it can visualize it much better. So whenever we tend to have a low volume water jet, so the bleed which is happening, we tend to the vision will get obscured. So always have a high flow water jet. So it will give you the optimal visualization of the bleeder, and it will help us to do the proper endotherapy. And like which stent are we going to place? This is like whether it is a plastic or metallic. So that will be discussed in the next subsequent slides. The management of post ERCP bleed and peptic ulcer bleed is very similar. So because we tend to use adrenaline injection, heater probe, clip, hemospray, and rescue is always an angio as or the surgery. But two things which are different in the post ERC bleed are usage of a 912 millimeter balloon, that is our stone extraction balloon, which can be used as a tamponade. Like we can insufflate at the apex of the keeping the balloon in the bile duct, and then we can insufflate so that it can tamponade effect, or else we can place a fully covered metallic stent. So apart from this, the management of post ERC bleed and peptic ulcer bleed are similar. So coming to the injection, so similar to that, like peptic ulcer, like 1:10,000 diluted adrenaline we tend to inject predominantly at the apex of the cut. So like we see that this is a cut that has happened, it is oozing from there. So we try to inject that. In peptic ulcer bleed, we do a 4 quadrant. Here we tend to do only on a semicircular fashion at the apex, such that the underlying submucosal vessel can be separated from the mucosal breach that has happened. So we don't inject on the bottom area because that's where the pancreatic orifice is going to open, and at that time there can be a chance that post-procedurally pancreatitis may happen. In prospective study of 79 patients, like 100% success and minor bleeding rate is only 14%. So this is a study again by Todd Barron et al, where after the injection you can see this blanching that should happen. That means we have injected in the proper plane. Suppose we tend to have a clot similar to the adherent clot, we try to gelatin it with the snare and then try to identify the bleeder to do the definitive endotherapy using a mechanical or a thermal. Thermal, we tend to use heater probe, so we can see that the bleeding spot is here. So we try to put a heater probe and then we cauterize it so that the bleed rate can come down. So this is a proposed algorithm for treatment of immediate post sphincterotomy bleeding. So this is whenever immediately following a sphincterotomy, still intra-procedural. So if at all the visibility is good, so that we continue on the procedure. If at all the visibility is not good, we wash with water, and then if the visibility is good, we continue the procedure and we do the definitive therapy. If the visibility is improper and we find that the bleed is significant, then we inject, and if the bleed is controlled, we continue the procedure. If the bleed is not controlled, so then we tend to add on to another endotherapy similar to the dual modality of treatment, where we try to put a clip or a heater probe. And then we try to abort the procedure, and 48 hours later we can redo the procedure, or if the person continues to bleed or something, we may have to go for angiography or embolization or surgery. So peptic ulcer bleed generally has got a big role for proton pump inhibitors, but a large observational studies has shown that either use pre-dose with esomeprazole or continue esomeprazole, it doesn't reduce the risk of either intraprocedural or delayed bleeding. Dual modality of therapy is much better in this retrospective study, so where they have combined epinephrine along with thermal therapy, and you see that the initial hemostasis reaches 100% with a rebleed rate of only 12%, whereas with just adrenaline alone it is only 96% and a rebleed rate which is little higher than the combination therapy. So it is always better to have a dual therapy. So like this is one of our case where a couple of old stents were there. Once we remove it, so there is a bleed. There's a patient who had malignancy, and after that we have exchanged the stent, and that became the tamponade effect and became better. So we placed clips like in patients who tend to have a significant rebleed. So the most important precautions that we always take is like we should not do any mechanical or thermal therapy at the bottom. So the dictum always says pancreatic duct comes at the bottom, that is at the floor of the papilla, whereas the bile duct goes to the roof of the papilla. So whenever we try to cannulate, we go to the roof, that is bile duct, and the mechanical or thermal therapy should never be applied at the close vicinity at the bottom, because it should be removed, otherwise they cause ductal obstruction and then subsequent cholangitis or pancreatitis. How are you going to prevent? So either by placing stent, but most important recommendation that ESG tells is it's always better to have a nasobiliary drain in place, because we keep flushing the duct and chance of cholangitis happening again will not be there. Intervention radiology and surgery, these two people are our main people whom we go for rebleed scenario. But in endoscopy suit, we can always place a fully covered metallic stent, which can be removed in 4 to 8 weeks time, because it will significantly reduce the bleeding rate, because the diameter is almost like a 1 centimeter, and as well as there is lesser chance of blood transfusion requirement. Couple of other modalities which have come recently is a hemostatic powder. So like these are all rescue therapies. ESG doesn't recommend that, but rebleed rates are much better whenever we tend to use the hemospray. So this is from Wilson Cook. This achieves hemostasis by concentrating the clotting factors by forming a mechanical plug on the vessel. So such that whenever the powder is sprayed at the bleeding spot, especially when the vision is not so clear, so then we try to use this with the delivery catheter, which is connected to a carbon dioxide canister, and the powder will spill and the hemostasis can be achieved. So it will give a temporary benefit. So definitely like 48 hours, the amount of bleed will definitely come down, but it has not yet come into the recommendation. Embolization of refractory post sphincterotomy bleed is definitely yes. So here we take the help of intervention radiologists who try to do the arteriogram and then try to identify the where exactly is the leak. And once we identify, then we try to coil embolize that area, and you can see that in the subsequent slide there is no bleed. So the endoscopically placed metal clips, which are stainless steel, that will give an indirect marker like what will be the culprit vessel or where is the culprit vessel that has to be coiled. So that will give the roadmap for the radiologist. So that was taken from the article. So risk factors for delayed and severe post-sphincterotomy bleed in a retrospective study of 161 patients is predominantly whenever a person who had an initial moderate bleed or a person is jaundiced. So these two are very important risk factors for severe bleed. So this is a proposed algorithm for treatment of delayed post-sphincterotomy bleed. So like the first important thing is the ABC, airway bleeding and circulation, like where we need to resuscitate the patient. So once the patient is stabilized, then we take up to the endoscopy suite. Endoscopy reveals a clean ulcer at the cut site, no need for any endotherapy. If a person has got an adherent clot, so then aggressive irrigation with a high jet water pump, or we can gulleton the clot using a snare forceps after we inject the adrenaline in a semicircular fashion. So once we remove the clot, then we find that the stigmata or we find the bleeding vessel, then we do the double therapy, which is a mechanical using a clip or a heater probe. So suppose whenever it is continues to bleed, then the rescue will be angiography, embolization, or surgery. So the take home message is always extend the cut, complete the cut. So don't do a half cut. So then the vessel recoiling will be a problem. Either we spray or inject adrenaline, predominantly diluted 1:10,000. So we can use the 912 stone extraction balloon at the distal end of the bile duct as a tamponade effect, such that the bleed can be controlled. So we use a high water jet such that the visibility is not a problem. We do thermal devices to control the bleed, and rescue is always a intervention radiologist or a surgery after we place a nasobiliary drain or a fully covered metal stent in case of rebleed or a refractory post sphincterotomy bleed. So whether there is any role of endoscopic ultrasound to see the bleed, the culprit vessel, what is the diameter of the culprit vessel, or the rebleed rate is much more, where we can do a fine needle injection of either a coil or a glue, because nowadays we are coming up more and more on vascular endotherapy by endoscopic ultrasound is still a research question. So that concludes my talk, and thank you for patience listening. Thank you, one and all.
Thank you very much, Avinash. It was a very nice lecture. I think in our clinical practice, we should always look for the immediate bleeding, and that will suggest that post sphincterotomy bleeding will later on occur or not. So, in our clinical practice, we do sphincterotomy, and then if the patient bleeds, we extend the cut, we do the saline adrenaline injection, and if it continues to bleed, we do the heater probe therapy or gold probe therapy. And even if it still started bleeding and then it does not get controlled, we immediately go for the covered metal stent. It is now our routine practice that we use covered metal stand more and more, and it almost always helps, except one patient where it again bleed, and patient has to go for this embolization therapy. So I think it is better to predict the delayed. You can predict the delayed bleeding also while the first therapy only, because if patient has severe bleeding at the first time, it has more chances of bleeding later on also. So you have to be very careful. We are using more and more fibrin glue also. Like we use Endocryl as fibrin, as good as fibrin glue for bleeding post sphincterotomy, and we have used Endon gastroscope with cap to place clips, because most of the bleedings are at the sphincterotomy site. So we can use the Endon endoscope with normal Olympus or any other clips to control this bleeding. Umesh, what is your opinion?
Yeah, thank you, Sanjay. I think Avinash has covered it, most of it, and you have added few points. Very relevant, I think, in the post ERCP bleeding setting. Most of the times in the ERCP, post ERCP bleed, they'll stop by the time you finish the procedure. And whatever, whether it is a pre-cut related, most of the times it's a pre-cut related bleeds are not heavy bleeds, and they're mild loose, and they stop, while you are trying to cannulate. And the sphincterotomy bleeds, it bleed at the apex, and by the time, most of the times you finish the procedure, it will stop. But in case, certain cases, if it is a little excessive, you can use adrenaline or balloon tamponade in the common scenario. As you said, I think most of the times we use, this thermal methods. You can use the coagulation part of it. When you use a cutting current, suppose there is a bleed, you can use a coagulation current and stop it. Most of the times that will help. As you said, off late, I think in many centers, putting a SEMS, self-expanding metal stent, will be sufficient, and that will prevent, patient going for IR or surgery. Most of the times that will be sufficient. One other point I want to add is, especially in the setting of EHPVO, extrahepatic portal vein obstruction, if there is a bleed or if you anticipate bleed, it's mandatory to use a US and assess the pericholedocal vessels. And if you see one, probably you can cover such patients with terlipressin as a preemptive measure. So that's the only addition. Otherwise, most of it is, I think, nicely covered. And are we discussing the pancreatitis again?
Yeah.
Okay.
So I will ask a question to Dr. Chatterjee. What is your role? How do you suggest that? How do you in your clinical practice prevent this post ERCP pancreatitis? What are the measures you use?
You have to unmute, Chatterjee.
Can you hear me now?
Yeah.
Yeah, sorry. Thank you for the question. So as Dr. Nalini Gouda has nicely elucidated, there are patients whom are considered risk for pancreatitis. For example, if they have had previous pancreatitis, if they are female patients, if you're doing on normal ducts, or you're doing pancreatic endotherapy, these patients are at high risk patients. So most of the patients in our clinic, we are giving intravenous ringer lactate pre-procedure, and we are continuing it 1 to 2 hours post-procedure. We are not, if once we're trying to do cannulation, we are trying for cannulation for about 5 minutes if you have got a fellow. After 5 minutes, usually the consultant will take over from the registrar or the DNB, and we do not allow the fellow to keep on trying for more than 10 minutes, because we have seen that if they try for more than 10 minutes and then the consultant takes over, then the risk of pancreatitis is usually more in those patients. And we also don't give high risk patients to our fellows to start, usually large duct, big stones, normal ampulla, we are giving those patients. Post procedure, we are giving rectal endomethacin on most of our patients. If the pancreatic duct is cannulated by the guide wire more than 3 times, we are usually putting a single pigtail, single flange pancreatic duct stent. But if it's going once or twice, we are usually not. And we are not usually using dye to find the way, using wire guided cannulation. So these are the main methods that we are using to prevent post-ERCP pancreatitis.
Very good points, Chatterjee. I think most of the centers, I think, follow your practice. And these are all the standard practices to prevent PEP, that is post-ERCP pancreatitis. Just want to ask any of the panelists, is there any role for ulinastatin?
I don't think so.
Hmm?
We are
No,
not trying. It's too
very
costly.
costly. Yeah, it's very costly, and it has not shown any effectiveness even after the high doses.
I think 3-4 years back, I think few
Yeah, the
came up
company people are still promoting it, but it's not useful.
Yeah.
I want to ask Dr. Jha. Dr.
Yes.
Jha,
Yes.
yeah, what precaution you will take while doing ERCP in a cirrhotic patient who is having deep jaundice? What are the complications which you can encounter during this, and what are the precautions you will take?
In cirrhotic patient or portal hepatitis without cirrhosis, in such cases, first, if we have imaging diagnosis, then actually we go for the endoscopy and see if any varices, or in imaging there are a lot of collaterals. If collaterals are present or varices are present, in that scenario we take some extra precaution, and precaution in the sense of, actually sometimes I do the US periampullary US to see the collaterals around the papilla, because sometimes collaterals just around the papilla and epithelial tissue. So we can take extra precaution in that case. Number one. Number two, if there are a lot of collaterals, actually, and patient is in cholangitis, in that scenario, I don't go for sphincterotomy in the first time. Actually, we place the stent and then wait to resolve the cholangitis. And then we try, once PTN and other things actually recovers, then we try in the second attempt for the sphincterotomy in a very careful manner. These two precautions actually we exercise in patient of portal hypertension. And one more thing in these patients, because sometimes even if prothrombin time is normal and platelet count is normal, so bleeding risk is still there. So we always keep this FFP and platelet count and standby. So post procedure if bleeding happens, and if happens, then we actually exercise the same practices the non-cirrhotic patients for the hemostasis, like APC, like cautery, use of cautery, and other cleave hemocleaves and other things.
I think two more things I would like to suggest in cirrhotic patient, that if they are very deeply jaundiced, anesthesia risk is very high. We have seen, even if after ERCP patient may not come out, even if you have reduced the cholangitis and sepsis, patient may not come out of anesthesia if patient is given deep general anesthesia. So I would like to tell people that anesthetists should be aware of the complication post ERCP also. So they should be prepared beforehand to give the minimum anesthesia that the patient should come out of anesthesia. And second thing is, if this patient, cirrhotic patient, they are very fragile, they have tense ascites. So always tape ascites before you want to do ERCP. If you encounter that you have to take a long ERCP time, if you have large stones, so it is always better to tap the ascites beforehand, because they have a respiratory complication after the ERCP. Umesh, what do you say?
Yeah, I think. Maybe Dr. Jha, you want to add?
No, I agree with these two advice. Actually, we should do the procedure in minimum sedation, so the first recovery.
And Dr. Mukesh is also there. So Mukesh, do you want to add any point to prevent the pancreatitis or bleeding?
Yeah, now I think the topic is comprehensively covered and other panelists has reasonably contributed. Only thing what I wanted to suggest was the frequency with which it is suggested that we should PD stents. We are not doing it, and I've been asking about my Rajasthan group also. We don't do it that often. Yes, we are using NSAIDs for prevention of post ERCP pancreatitis. So I don't know over the time whether there needs to be a relook on this data.
According to me, I think it definitely helps, because we have seen that when we were not putting pancreatic stent before, like 10 years before, there were severe pancreatitis, because it definitely prevents the severe pancreatitis. Not even if it is not doing the acute pancreatitis, it cannot prevent the acute pancreatitis, but it can definitely prevent the severe pancreatitis.
No, I agree with Sanjay. I think there is no controversy as far as putting up a stent. If there is a pancreatic injection, or if there is some problem while doing the biliary cannulation. But only thing, the controversy would be the threshold.
Threshold, yes.
Whether you would like to place a stent, pancreatic stent, even if single wire goes in even once, as Dr. Nalini Guda says. But I usually do not prefer to place a stent if the wire accidentally goes in once, maybe 2 to 3 times or more than that frequently. If it goes, then you are
And
not.
especially in high risk patient, if it is in, you are having a high risk, because it doesn't matter you go for 10 times in chronic pancreatitis.
Yes, correct.
They don't get pancreatitis so often.
Yeah, this is the usual patients, not chronic
So clinical scenario may be different whenever you want to put it or not.
That's one thing. And second thing, what should be the timing of pancreatic stent removal?
I think it's 2
Within
to 4
5
weeks.
days.
I think it is 2 to 4 weeks.
Yeah, I think 4 weeks is a
better to remove early. Better, because they have seen that chronic pancreatitis and there are chances of stricture developing if you keep it more than 2 weeks. There are chances of developing.
We are removing the pancreatic stents within a week. And we are doing an X-ray to see whether they have fallen out on their own, and if they have not fallen out, we are just removing with a gastroscope.
Yeah, that you can see on your image intensifier also. So
that's right. That's what we are doing.
No need to do the X-ray because
in the image intensifier. That's what.
But you know, you would have done ERCP. Patient goes for cholecystectomy, and suppose you would have placed a stent, and you would like to remove the CBD biliary stent removal as well. So you could
remove after 4 weeks, both at the same time. You can remove.
You can remove both of them at the same time.
That's right.
Okay.
I have a question. Can I ask this question? Sure. I am a bit reluctant about using heater probe in post-ERCP pancreatitis. Thermal therapy is usually not very well recommended. Yeah, I know some of you are saying that you are regularly doing, but what we are doing is we are injecting adrenaline, trying to put clip. If we cannot put clip, we are using a gastroscope with a cap. And if these two don't work, we are straight away going for fully covered SEMS. We are actually avoiding thermal therapy because we have had in the past 1 or 2 episodes, even after aiming at the apex, severe pancreatitis because of using thermal therapy. So I am a bit reluctant to use thermal therapy for post-ERCP sphincterotomy bleed.
Yeah, I think if you are doing thermal therapy, usually you should put a pancreatic stent. That will prevent this. So if you are going to use the thermal therapy, it is better to put a pancreatic stent beforehand.
Actually, when there is a lot of bleed and everything is happening at that time, trying to cannulate the pancreatic duct is not that easy.
No, after control of bleeding.
Yeah.
When you control the bleeding with thermal therapy, you always put a pancreatic stent and it definitely helps.
No, rather than you can use a coag part after using a cut.
Yeah, so we are using that. We are pressing the blue pedal of the and not to just at the apex. We are aiming at the apex with the board. That is what we are using, but we are not using heater.
I agree with you. Fair enough.
Now you can use co-grasper also. That is also very good. Rather than using the hot biopsy, which is very big, you can use the co-grasper, which is very small.
Yes.
For thermal therapy.
I think.
That's a good suggestion, Sanjay.
Thank you.
Do we have time?
Another
I think we have to conclude.
More than co-grasp is quite a useful accessory, and completion of sphincterotomy also helps in bleed.
Yes.
Yeah.
Sahil, do we have time now?
Yes, sir.
No,
sir. Sir, time yes.
Okay, so now
are there any questions?
I would like to thank you all.
Thank you very much.
Thank you very much for joining this excellent talk and then having a great discussion. Thank you.
Okay. Thank you, organizers. Thank you, Sanjay, and all the panelists. Mukesh, Chatterjee, Ja.
Thank you.
Thank you, Ja. See you. Bye.
Bye-bye.
सर हेलो सर
Hi, hi Vishal. How are you?
गुड सर आप कैसे हैं
Oh well, all well. तो कैसा है?
ऑल गुड सर
So good to see you, Vishal.
थैंक यू सर
तो हम लोग और कुछ बात करेंगे ना, जो हम लोग 2-3 प्लान किए थे ना, कॉन्स्टिपेशन वाला, तो वो बात करेंगे
यस
ना।
ठीक है सर मैंने मेल डाला था बट वो सर ने कुछ
हाँ, नहीं, मेरी बात तो फिर साथ हुई नहीं, तो we'll talk about that. है ना?
ठीक है आई गिव यू अ कॉल
हाँ, आज ही कर लेंगे तो I think we should start working on that.
ठीक है सर
How the conference going? पता है? How the conference going?
सर मैंने थोड़ा बहुत देखा था इट वाज गुड वो थर्ड स्टेज चल रहा था कुछ
Right. I hope audio should be good.
समटाइम्स
Yes, sir.
Sahib, we'll check out the audio so that I can see my screen to just check that everything is fine.
Yes, sir. Audio is okay. Audio and video is okay, sir.
You check my screen also?
Yes, sir. Yes, sir. Perfect.
It's visible, huh?
Yes, sir. It is visible.
I have a video also, let me run the video.
Yes, sir.
Run a video.
Yes, sir. Yes, sir.
Vishal, you can also check your slides.
सर आई हैव गिवन देम अ वीडियो आई थिंक दे
Yes, sir. Yes, sir. Yes, sir. We have your video, sir. Dr. Vishal, sir. We will share from our side, sir.
Sahil, are you on time?
Yes, sir. Yes, sir. Yes, sir. Our session will start on 3:45, sir.
Are we on time? We're running time, on time.
Yes, yes, sir.
Perfect.
दिस हॉल इज vacant right now so it doesn't matter so we are going to start it off
No, but there must be something going on in this hall, no?
no
Yeah. Is it a new hall now?
I think there is nothing sir
Okay.
I just checked it I think there was nothing hello
Good afternoon, sir.
hello Dr. Sridhar
Good afternoon, Vishal sir. कैसे हैं?
श्रीधर एकदम ठीक. अरे श्रीधर, I've sent an email, it bounced back.
अच्छा.
So मैं भी WhatsApp पे वो कर रहा हूँ. देखो
कोई
WhatsApp.
नहीं sir.
Tell me your email ID again फिर से.
Dr. Sridhar Sundaram at gmail.com.
Oh, जो मेरे पास में श्रीधर SRI ना
SRI है sir. SRI.
श्रीधर सुंदरम.
Yes sir.
@
gmail.com sir.
Murshidhar, how are you doing?
I'm fine sir. I'm fine.
What's up? क्या चल रहा है?
Sir,
All good?
actually, हाँ मतलब there are some changes that are going on. I'm likely to leave KEM, so that's what's going on.
Okay, मतलब KM you
टाटा ही होगा तुम
हाँ
कहाँ टाटा जा रहे हो
हाँ
Sorry.
because people actually हमारे सिर्फ वो JSG का fellowship का था some issues, so they are actually not.
You got the JSG fellowship, no?
I did get the fellowship, sir, but I think the KM admin is not allowing me to go. There are some issues, some special permission from the municipal commissioner and all that, and then they're asking for a 7-year bond. 7 years is
After going there.
Yeah, so 7 years is I thought was a little much, sir. I mean,
I agree.
yeah, I mean, I cannot commit for that long. I mean, if it were 1 or 2 years, maybe I would have definitely not said. So that's what's going on, sir.
But you are granted otherwise, no?
Yes, sir. I got the mail yesterday. They have already, I mean, sent me the visa process documents. So I think we'll start that.
Perfect. That's very good.
Yeah. So I'm in the.
Which university?
So Kyoto Prefectural University.
Okay.
Yeah.
And this is mainly dedicated to what specialty? Endoscopy?
Sir, image enhanced endoscopy and image enhanced endoscopy and third space, sir.
6 months, no?
6 months, no? Actually, 5 months, sir. 5 months. They've already sent me a mail saying 5.5 because of COVID. I'll have to quarantine for a few days. So.
Right. And when are you going to start your fellowship? What is the timeline?
July, sir. July to November.
Right. Wonderful.
Congratulations, Sridhar.
Thank you, Vishal sir. Sir, आपके राह पे चलना है थोड़ा.
हाँ?
आपके राह पे चलना है.
नहीं, you have gone beyond because I also applied. I didn't get.
अच्छा. I did not get it last year. I think Saurabh sir गए थे एम्स से.
हाँ.
तूने कब अप्लाई किया था? When did you apply, Vishal?
So last year. I think Deepak went और सौरभ went तो उसके पहले.
सौरभ गया था.
हाँ. उसके पहले.
हाँ 2019 की बात है. 2019 में I think डॉक्टर सौरभ गए थे.
सौरभ 19 में. 18 में मैंने किया.
नहीं बट अब ऐसा है कि विशाल सर वैसे अभी वर्ड के रीडिंग एक्सपर्ट हो गए एब्डोमिनल ट्यूबरकुलोसिस पे. तो
यार
तो उन्हें ये फेलोशिप की जरूरत नहीं. अभी उनके अंडर आ रही है थोड़े दिन में फेलोशिप.
Absolutely.
So fluke, I don't know how it works, but ठीक है.
See, I mean that is your humility, but the fact is there is clearly some amount of effort that you put in, and clearly you are reaping the rewards for that. So which is why.
PJ में बैठने का फायदा.
नहीं सारे सर जी आप भी. In 3:45 will start, right? Panelist कोई join नहीं हुआ.
I think.
Sahil, 3:45 at around 3:44. Just play the slide of this session, and at 3:45, the lecture will begin. Exactly at 3:45.
Okay.
I think Dr. Lakshmikant has joined, right?
Hi. Hello.
Hi.
Hello, sir.
Hi, Lakshmi. How are you?
Hello. Fine, sir.
Dr. Lakshmikant, I'm assuming you're based in Mysore, right?
No, I'm in Hubli. I was in Mysore 3-4 years back.
Okay. No, I got some basic
Okay.
details, so which is why I was wondering if you're still in Mysore or.
No. I am in Hubli. It's in North Karnataka.
Okay.
Yeah.
Thank you.
Yeah.
Vishal, couple of things, na? Like in chronic diarrhea, there's a
Listen until now your name has come at least.
quite there's a lot of gap. There's a lot of gap in the both understanding and the guidelines. I told you last time that we should draw guidelines on chronic diarrhea. How do we approach? How do you follow?
Right.
There's a lot of gap there. It requires a bit of more systemic review of literature.
Sir, I think, sir, now I'm pretty, matlab I would have some time now. So if you suggest we could do a systematic review to begin with.
एक बात कर लेंगे ना certain topics पे like functional diarrhea पे what are there available. A lot of things are there. I think we should do that. And even global literature, there's nothing much in chronic diarrhea. Disease-wise, there is celiac disease, IBD, lots there. But as a syndrome, we need to have a more on that. I think yes. We'll talk more about maybe sometime later.
Okay, sir. I'll give you a call later today, sir.
Yes. Mallikarjun, good afternoon.
Good afternoon, sir. How are you, sir?
Very well. How are you?
Fine, sir.
Where are you now, Mallikarjun? Where are you now?
I am in St. John's Medical College, Bangalore.
Oh, wonderful. You know Vinita there, na? In rheumatology.
Who, sir?
Vinita.
Yeah, sir. Yeah.
She's my batchmate.
Okay, sir.
Will you give us a countdown when they're live?
Yes, sir, we will do that.
Yeah, thanks.
Sahil, have you given share screen access to Dr. Makharia?
I do have. I can share the screen.
Yes,
Okay, sir. So I'll just give a countdown. I'll give a reverse countdown of 5. And then you may begin, sir. Sahil, ready? Sahil?
Yes, ma'am. I have already shared my screen.
Okay. 5, 4, 3, 2, 1. Sahil, you may stop the sharing.
Very good afternoon to one and all. I welcome you all. I'm Dr. Sridhar Sundaram from KM Hospital in Mumbai, and I welcome you all to this session for the midterm Endocon 2021 for the afternoon session on 2 topics that are very relevant to clinical practice in gastroenterology: the role of endoscopy in the evaluation of chronic diarrhea and eosinophilic gastroenteritis. Amongst us, we have 2 speakers who are stalwarts in their fields. We have Professor Govind Makharia, who's professor in the Department of Gastroenterology at the All India Institute of Medical Sciences in New Delhi. He is one of the leading experts in the world on celiac disease, and he's going to be speaking on the role of endoscopy in chronic diarrhea. The second topic is going to be covered by Dr. Vishal Sharma. Dr. Vishal Sharma is associate professor in the Postgraduate Institute at Chandigarh. He's a dear friend and one of the experts of the world in abdominal tuberculosis. He's going to be covering eosinophilic gastroenteritis. We have with us a panelist, Dr. Mallikarjun from St. John's Medical College in Bangalore. We also have Dr. Vaibhav Somani from Bombay Hospital in Mumbai. And we also have Dr. Lakshmikant Desai, who's based in Hubli, who's a gastroenterologist from Hubli. And we have three chairpersons, all Dr. Kaibalya Ranjan Das from Orissa, from the SCB Medical College in Cuttack, Dr. Sambit Behra, who's also from the SCB Medical College in Cuttack, and Dr. S.K. Jina from Sun Hospital in Cuttack. So without further ado, I call upon Dr. Govind Makaria. Sir, if you can share your slides and start with your talk.
Thank you, Dr. Sridhar. Thank you, the team, organizing team of Endocon. This has been a wonderful meeting, and we had a lot of feedback. That meeting is going wonderful with a lot of people listening to the Congress. So good afternoon, everyone. As Dr. Sridhar introduced, that what we're going to discuss now is the role of endoscopy in chronic diarrhea. I hope I'm audible, well audible.
Yes, sir. Yes, sir. Yes, sir.
Right. So over next about 20 minutes or so, we'll look at what are the indications and what do we see, why should we do endoscopy in those patients presenting to us with chronic diarrhea. Before we go there, I have nothing to declare. And the learning objective of this talk would be that when to do endoscopy in those patients coming to us with chronic diarrhea, what endoscopy examiners want to do, and what are the best practices for obtaining biopsy. In addition, I'll discuss a couple of cases, some common errors we do in this field, and some good practice point. So look at chronic diarrhea as an important disease in our community, and almost 10 to 11% of our population have chronic diarrhea. If you look at the population of our country is about 1300 million. So if 10% becomes about 100 to 130 million people in our country has chronic diarrhea. So chronic diarrhea is an important disease for all the physicians and gastroenterologists. And therefore, is important that we know about this disease in much better detail. Furthermore, of these large number of patients with chronic diarrhea, majority of them are functional in nature. I will come back to that in more detail. So let me start with a case. This is a 38 years old female who came to us, who had a new onset diarrhea for last 6 months, which was large volume and watery. And she has urgency. Once you have urgent desire to pass stool, and she rush to washroom, and as sits in the washroom, she will pass large amount of watery stool. And she has multiple such episodes per day, and she had no blood. She had mild abdominal pain, which used to get relieved with passage of stool and no weight loss. So this case scenario, how do I approach and which endoscopy do I do in this individual? And I'll come back to that. Before that, she was given multiple antibiotic and there was no response. So we'll come back to what test we'll like to do in this individual. So I will leave you with this case, this point of time, and go to some basics about approaching a patient with chronic diarrhea. And we'll come back to this case after we had discussed the basic approach. So once you talk about chronic diarrhea, there are three key points. And the key points are frequency, the fluidity, and volume. And 3 points are the most important point which help us in locating the site of disease of chronic diarrhea. Therefore, more volume can occur because of acute diarrhea, which is mostly secretory. More volume can occur because of malabsorption. If there's a diffuse mucosal disease, there will be malabsorption, or there any cause in the GI tract or outside GI tract, which leads to a lot of neurohormonal secretion that can lead to secretory form of diarrhea, which is more of a watery in nature. And we know diarrhea occur because of whatever we eat or whatever we drink, they get digested, absorbed, left out goes to colon. Colon further absorbs what is left out, and little amount goes to the stool. If there's imbalance, if there's a malabsorption or if the colon is not functioning well, then they will be more effluent. And this balance is very important. One must remember there could be there could be diffuse mucosal disease of small intestine, but patient may not have diarrhea because the colon will absorb a lot of things which comes through IC valve to the colon, and colon can absorb a lot of water, and therefore the volume of stool, which was volume of effluent, which was large from small intestine to large intestine, but ultimately it could be a small volume. So please remember that what we see is output may not be reflective of the severity of the disease. Furthermore, the frequency of stool is decided by rectum, not by small intestine, not by large intestine, not by IBD, not by celiac disease or infus disease. Is the rectum. Rectum has the mechanism of sensory fiber. It senses afferent, center, efferent, and therefore the defecation. So rectum is disease because any cause, be it hypersensitive as occurs in IBS or inflammation as occurs in IBD, they will have more frequency. So patient with UC has more frequency compared to Crohn's disease if rectum is not involved, because in UC rectum is always involved. But in IBS, rectum is generally involved. They have more frequent. And again, bringing all the 3 points, the fluidity, frequency, and volume all together, high frequency, high volume, content is watery, is nothing but secretory diarrhea. Secretory, acute condition is infective, chronic is a neurohormonal secreting state, and there could be multiple causes of that cause. High frequency, high volume watery is secretory diarrhea. High frequency, low volume. Frequency is high, volume is low. It could be large vowel type. It could also be small vowel type, as I said, because the high frequency is because of mostly because of large vowel type. In the small vowel type, the frequency could be high or even normal. Volume could be high or even normal. So one may not distinguish this. But this is very clear. High frequency, high volume is mostly secretory in nature. Therefore, the diarrhea can occur from the disease for small intestine, large intestine, or rectum. So we all know the cause of small bowel disorders which can lead to diarrhea is simply the diffuse mucosal disease for any nature, be it celiac disease, be it tropical screw, be it immunodeficiency, be it Whipple's disease, be it IPSID or any other disease. If there's a diffuse in nature, it can lead to chronic diarrhea of small intestine type. It can also be because of a luminal phase maldigestion, because of chronic pancreatic disorders, or chronic bile acid deficiency can also lead to luminal maldigestion and can lead to diarrhea. Furthermore, after absorption, there's no transport mechanism. After absorption from intrasite, the nutrient has to go from intrasite to the lymphatics or to the blood circulation. If there's a lack of carrier proteins, it could be A-beta lipoproteinemia, and that can lead to diarrhea. Or if the lymphatics are blocked because of either primary or secondary lymphatic block, that condition called lymphangiectasia, they can also have a diarrhea. Coming to large bowel type, all we know very well that it could be functional or it could be organic. Functional, it could be IBS or functional diarrhea. It could be IBD, it could be microcephalitis, a number of other causes. One must remember, this is not a common practice, but must remember, we get a lot of patients who have a secretory form of diarrhea. As I said, large volume watery diarrhea, and their causes neurohormonal secretions. It could be drugs, metformin, olmesartan. It could be autonomic disturbances, autonomic neuropathy, or autonomic enteric neuropathy, and bacterial overgrowth, and a number of multiple other causes. So look at it. If you do endoscopy blindly in these situations, we may end up with no diagnosis. So it's very important first to clinically assess what is my clinical difference diagnosis and what test do I do to make a diagnosis. Normally, I recommend and practice these 8 points in a patient with chronic diarrhea. But here for this lecture, we'll consider functional organic, small bowel, large bowel type, and volume and content of stool. And these 3 points are really very important, which will help us localizing site of disease. If I know site of disease, I can target my investigation. If I don't know what test to do, patient requires diarrhea. If I don't know small bowel type, large bowel type, do I do upper GI, do I do colonoscopy? I may remain confused. So it's important that spend little time with patient, ask these questions, make a framework in mind, and make a differential diagnosis and choose right form of investigation, including endoscopy. Therefore, locate the likely organ which has led to diarrhea and plan investigation. 3 principles of investigation. First principle, look at the effect of the disease. We will not discuss for this talk, like looking at hemogram, the effect of disease, nutrition, other parameter, and look at etiology of why it happens. But in between, the most important, you want to know what is the structure and function of an organ which led to diarrhea, right? And here comes endoscopy. As I said, that you always want to look at structural disease, look at the patency of intestine, and look at a structure, microstructure of a GI tract, upper GI or lower GI by doing endoscopic biopsies. Mostly mucosal, sometimes transmural. And functional, we know, of the 4 layers of intestine, these 2 layers, that is the epithelial layer, that is the mucosa, is a functional unit. For the 4 layers of intestine, mucosa is the functional unit, and so is the muscle layer, is the functional unit. Rest 2 units, 2 layers are supportive in nature. Very important, very essential, but supportive. But this is the functional unit of GI tract. Therefore, the biopsy of this mucosa is extremely important to tell us the cause of chronic diarrhea. So what is objective for endoscopy examination? Now, with this basic introduction, look at coming to endoscopy. Why we do endoscopy in them? You want to look at the architecture of how the mucosa looks like. Sometimes there are certain conditions where you find classical features which can direct us to particular diagnosis. But most importantly, we want to look at the histology. Means you look at histology, which can be done, you do routine histology, and also for sometimes special stains. You want to do biopsy for microbiological tests of different kinds. Also, we do endoscopy sometimes to spirit duodenal fluid or jejunal fluid for specific purpose. You want to diagnose SIBO or bacterial overgrowth, you do culture. You want to diagnose Giardia or alpha or IPSID, then spirit the fluid for alpha heavy chain. And also we do endoscopy to look at length of disease, how much is affected, especially in IBD. We always do colonoscopy to look at length of the disease involved. Which endoscope? Most of the time, simple white light endoscopy is fine and diagnostic. Narrowband imaging or endocytoscopy are still investigational. They, if available, you might do for your own learning, but they will not add to diagnosis. So never worry about it. I don't have a narrowband, I don't have endocytoscopy. It does not matter. You will do as good with white light endoscopy as you do with these endoscopy. In some conditions, the endoscopy is diagnostic. For example, if you say lymphatic dilatation or lymphoid dysplasia, a diagnostic, but in celiac disease, endoscopy may be completely normal. And purpose of endoscopy is to obtain, not only to see, but most important, to obtain biopsies. Now coming to, if your clinical investigation or clinical inquiry suggests that this patient has small bowel type diarrhea, it could be because with malabsorption or without malabsorption. With malabsorption, these are the causes. I think all of us know about these causes. And without malabsorption is a bile acid diarrhea or secretory form of diarrhea. So where do we endoscopy? Here we need to have endoscopy for sure, because we want to look at and want to obtain biopsy.
It's 4 o'clock.
But if it is secretory diarrhea, then probably endoscopy may not have much role to play. Same is for functional, same for large bowel type, functional disease or organic disease. And again, we know that in this group of patients, certainly we require endoscopy to know the disease and to map the disease. For functional diarrhea, endoscopy may or may not be done depending upon do we have any different diagnosis like SIBO or lactose intolerance or other disorders. So coming now to upper GI endoscopy. So normal duodenal folds, how they look like. When do we say atrophy? So if you look at 1 inch of duodenum, means about 3 to 4 biopsy forceps, open biopsy forceps. Optimal biopsy forceps about 0.5 or 0.6 millimeter or 0.6 millimeter. So if you have a 4 biopsy forceps open, like you have an impression about that, so over 1 inch, there will be 3 folds over 1 inch. And each fold depth will be about, this is a, from here to here is the depth is about 3 millimeter. And if you look at this is about 3 millimeter. The depth means the height and depth is about 3 millimeter. Less than that is called abnormals. Not only we look at fold, we also look at interdigital fold or what we call folds. We also look at interfold area, how they look like. And it's very important to examine them and then open biopsy. The endoscopy may look to be normal in many patients. It could be attenuated, it could be scalloped, it could be nodular, or there could be white nodules, or it could be thickened folds. For example, if you look at normal endoscopy, this is again finds a slight amount of rough kind of mucosa, which is not non-diagnostic. This is typical atrophic mucosa that you hardly see folds. This is called scalloping of folds, which is so-called feature of celiac disease, but may be seen in other disorders. If you have this kind of picture with chronic diarrhea, there's one diagnosis one can never miss. And you can diagnose this disease just by looking at a blood test. You look at LFT, look at protein. The protein, you find low globulin. If the globulin is low, think of glomerular lymphatic
In
hyperplasia
2 minutes, you can.
and become CVID. Because the CVID is a diagnostic. If you find these kind of whitish nodule, whitish spots on the endoscopy, this is just lymphatic dilatation, and this could be a diagnosis and take biopsy from these places. So a normal endoscopy does not mean they are normal structurally. They look normal, but they may be major disease, like conditions like celiac disease, tropical sclerosis disorders. They may have a normal looking intestinal mucosa. They may be atrophy, but they may look totally normal. Never miss out to take biopsy in them. If you miss biopsy, your diagnosis is missed. For example, large bowel diarrhea, you don't take biopsy, you do colonoscopy or sigmoidoscopy, find normal mucosa. If you don't take biopsy, you can never diagnose the microscopic colitis. And in secretiform diarrhea, all endoscopy are always normal. Therefore, in secret diarrhea, endoscopy may have no role at all. We may do endoscopy to rule out disease, other disorders, but all endoscopy may be normal. The biopsy may be normal in them. If you find, as I said, this kind of lesion is a nodular lymphatic hyperplasia, and if you do biopsy, you find no plasma cells, this confirms CVID, common variable immune deficiency, and it's very classical. And I can diagnose CVID just on basic blood test. LFT, low globulin in patient with chronic diarrhea is, think of CVID, and this endoscopy finding will further confirm. This is a typical lymphatic dilatation. Sometimes, just for academic interest, that one can look at these villi very nicely on white light and narrowband imaging. You put some water in the duodenum, about say 50 ml or 100 ml of water. You can see these villi so nicely seen villi, and also on narrowband imaging, you can see these villi so nicely. Obtaining biopsy is the key. Obtaining biopsy is the key, and a point I want to highlight for this evening, that biopsy is the key in the making diagnosis of in those patients with chronic diarrhea. So now we have two societies, the Indian Society of Gastroenterology and Indian Society of Pathologists and Microbiologists have joined hands together to make a joint guideline, which is called best practice guidelines for obtaining biopsy in small intestinal disorder. This guidelines for small intestinal disorder, and this is under publication. And a couple of points that how to take biopsy from these patients. So if you look at biopsy, this is important that the biopsy, once you look at these folds, so you bring your forceps there and always keep perpendicular. You like this, if this is the fold, I want to hold the fold like this, perpendicular to it, and take biopsy. If it is not perpendicular, then probably you will have a problem in interpreting the biopsy. So after we have taken biopsy, which is perpendicular to the fold, then you keep there, before you pull out, suck there for about a couple of seconds, then pull out the forceps to take biopsy. And after taking biopsy, you must orient. Orientation is very, very important for small intestinal disorder. What we do, you bring a forceps, you have white filter paper. Many departments don't just put the biopsy forceps in the formalin directly, but it's recommendation that most center would do is take out biopsy under this dissecting microscope and see the biopsy and slightly orient. Why orient? Because once you cut the biopsy, musculus mucosa, I can show it again. The musculus mucosa tends to enroll. The biopsy becomes enrolled. Therefore, you can't read them well. So put your forceps down to the filter paper and just unroll, because the surface is inside of the biopsy forceps. Unroll, slightly put from the corner, stretch out slightly, don't touch the center of it, and put in the formalin. Moving on. So how many biopsy? I'm talking about small intestinal disorder. Take biopsy both from second part of duodenum, post ampulla, and also from the duodenum bulb. And if you take biopsy from duodenum bulb, take at 9 o'clock and 12 o'clock position in the duodenum bulb, and D2 biopsy should always be from post ampulla. Furthermore, as I said, you take 4 to 6 biopsy, and if you increase the number of biopsy, your yield increases. Furthermore, as I said, the biopsy must be oriented in the endoscopy room. And this is an important practice point. Many of us don't do that, but I think it will be worth that we must orient biopsy in the endoscopy room. You will know yourself that my diagnostic yield has increased, and your pathologist will be very happy. Otherwise, I think some report here and there, because your biopsy is not oriented and you miss out the diagnosis. So orientation is a good practice point, and I think we should do that. Furthermore, that level biopsy, don't put all the biopsy in one bottle. For D1 different bottle, for D2 different bottle, for colon again every corner, every site you take biopsy into different bottles. This is also important to map out disease. Furthermore, that use fixative, and the formalin saline is a good fixative. Fix for 5 to 6 hours, and that's fine. And other common error we do that in the bottle in which you collect the biopsies, say 4 to 6 biopsies, there should be enough amount of additional formalin, 1 to 10 ratio. If it's not complete, then the mini biopsy will remain, will not be dipped into the fluid, therefore they will not be fixed. If they are not fixed, you will not be able to read them well. And transport them on the room temperature to pathology department. One of the most important point to highlight today evening, that please provide all clinical information, including serological test, to pathologists. And this is the most important point I want to highlight today, that you must involve pathologists by providing all the clinical information, which we miss many a times. Just any biopsy, they will find a biopsy report which is incomplete and non-diagnostic. But you provide all the details to pathologist, your colleague, you get a better diagnostic and even better yield. If you're thinking of A-beta-lipoproteinemia, always send biopsy for frozen section. Take biopsy in the formalin, and also take biopsy in the over foil on foil paper, and which is not in the formalin. And this is to be seen as a frozen section. Time will not allow me to explain this, but let's move on. If biopsy is non-diagnostic, don't biopsy non-diagnostic, thinking of celiac disease or tropical flu, and the diagnosis biopsy is not inconclusive, review biopsy pathologist. Make a call to the pathologist, tell him or her that these are my clinical situations. Please review biopsy again. They will take step cuts and give you better report. If review biopsy does not yield, repeat biopsy, and you might like to repeat a enteroscopy and do more deeper biopsies. In large bowel type of diarrhea, if we have a suspecting is functional disease, the functional diarrhea, always think of drugs or microscopic colitis as different diagnosis and take biopsy to confirm there's no microscopic colitis. Same if you think of IBD or radiation colitis, we like to map the disease, how much disease is involved, so do full length colonoscopy and do. For example, this patient who has come with functional diarrhea, and once you do biopsy and you find this patient has a collagen band just below epithelial cell, and this is a collagen colitis. If I don't tell my pathologist, they always will tell me, always, that this is a non-specific colitis, and you don't give damn to this report. Therefore, involving pathologists in making a diagnosis is a good practice point for resolving chronic diarrhea. UC and CD, I think we had a separate talk on this by Dr. Ahuja and Dr. Banerjee, so I will not go in that. But again, you know, UC for UC and CD, endoscopy is diagnostic. But point I'm going to make here is that please take multiple biopsy on different segment of intestine, and this is how we can make a diagnosis. And we have good data from our colleague at CMC Vellore that taking multiple biopsy makes difference to making a diagnosis. And also, we must take biopsy for for TB, if you have DDS tuberculosis, take for AB stain, for AB culture, and gene expert. This is the must. Coming back to patient, the lady who had come to us with a chronic new onset diarrhea, which we thought is typical of secretiform diarrhea, say large volume, watery, urgency, multiple episodes, large volume. So this typical secretary, and no form of endoscopy going to help in this patient. And endoscopy, if it only do, you find everything is normal. But here you have to do a different strategy and look at different tests. So here anyway, this patient underwent upper GI endoscopy, colonoscopy, all normal except for a segment of intestine showing lymphatic ectasia, but that is not the cause of her diarrhea. But lymphatic dilatation of this segment will not lead to the kind of diarrhea she had. So this is a misdiagnosis. Therefore, this patient requires specialized workup including chromogranule, protonoc, and hormone or chemokine assay. The point
Sir,
is that
sorry, sir, we
it is
have exceeded that time, sir.
yeah, I'm just closing.
Yes, sir.
The many patients, all patients of diarrhea will not require a endoscopic examination. Common errors what we do on target endoscopy. Patient has larval diarrhea doing upper GI endoscopy. Patient thinking of small intestinal diarrhea doing subendoscopy is not going to yield diagnosis. Let's be thoughtful and make a clinical diagnosis and choose endoscopy. Not obtaining multiple biopsy or orient biopsy is very important. Biopsy orientation is very important. And lastly, that we must connect with pathologists, give them adequate information to get proper diagnosis. With this, I think I'll stop here and take any questions if there are any. Thank you very much.
Thank you, sir. Thank you so much for the wonderful talk. I think we'll move on to the next lecture first, and then maybe we can take the questions at the end. So I invite Dr. Vishal Sharma to start with his talk on eosinophilic gastroenteritis.
At the outset, I would like to thank the organizers for the invitation to speak on eosinophilic gastroenteritis. Over the course of next 20 minutes, I try to cover both eosinophilic gastroenteritis and esophagitis. So whenever we talk about eosinophils, we tend to think about parasites. And whenever the question is about gastrointestinal eosinophilia, apart from parasites, other things which must come to mind are other infections like spiroketosis, drug-induced eosinophilia, eosinophilia as part of hypereosinophilic syndrome, which may accompany certain hematological malignancies, or associated with autoimmune diseases like Churg-Strauss syndrome, and then underlying GI diseases which may be associated with increased eosinophils like celiac disease or inflammatory bowel disease. The diagnosis of eosinophilic gastrointestinal disorders is to be made only in the presence of gastrointestinal symptoms apart from presence of eosinophils in the gastrointestinal tract. And this is only after recognized causes of eosinophilia have been excluded, like the ones we have already talked about. So eosinophilic GI disorders is a spectrum of many diseases, and these may include the eosinophilic esophagitis, gastritis, the involvement of the small bowel or the colon. Now, the term gastroenteritis is usually referred to for gastritis and enteritis. It must involve at least two segments of the GI tract. Esophagitis is not usually included in this particular terminology. Now, some parts of the bowel do have eosinophils normally. In fact, most of the bowel does have a few eosinophils, except for esophagus where eosinophils are abnormal. And the numbers keep increasing till around the terminal ileum and the cecum and the right colon, and after which, again, there is a decline in number of eosinophils. And that is the reason that the cutoffs which are used for diagnosis of eosinophilic disorders of a particular area or region are variable. So for esophagitis, it is usually a number of more than 15 per high power field. For gastritis, it is more than 30. For enteritis, it is more than 50. And for colon, it is usually variable for various sites, more for right colon and less for left colon, but has to be more than 25 per hypo. Now, there are a few differences between eosinophilic esophagitis and gastroenteritis. Esophagitis is primarily recognized as a mucosal disease, but we know that gastroenteritis could involve the mucosa or the muscularis or even the serosa. Now, the counts for diagnosis for esophagitis are pretty certain. More than 15 is consistent with eosinophilic esophagitis, but not so for gastroenteritis. And in fact, they are variable, and there is a lot of debate about the actual cutoffs. Then peripheral eosinophilia is very frequent with eosinophilic gastroenteritis, but may not be very frequent with eosinophilic esophagitis. And of course, for treatment, PPIs are one of the agents of choice for eosinophilic esophagitis, but not so for gastroenteritis. So the clinical presentation of eosinophilic gastroenteritis depends upon at least two components. What is the site of involvement? Stomach, small bowel, or colon, or the esophagus. And of course, the part of the bowel which is involved, whether it is mucosa, whether it's muscularis, or the serosa. So depending upon the site of involvement of the bowel wall, so for mucosal involvement, it could present with pain, but also with diarrhea, including bloody diarrhea. And there may be features of malabsorption, including iron deficiency or protein-inducing enteropathy, and failure to thrive could be one of the presentation in childhood. Muscular involvement is usually associated with obstructive symptoms, and the serosal involvement may present with exudative eosinophil-rich ascites. Now, coming to the clinical spectrum, and these are two studies from the same center in the United States which looked at data on eosinophilic gastroenteritis. And if you see that in 1990, the published report, which included patients over the previous 4 decades, showed that around 57% had mucosal involvement and 30% had muscular involvement, around 12% with serosal involvement. In the data which was reported in 2010 of the patients seen subsequently, a large fraction had mucosal involvement. Now, this may be because of the increase in access to endoscopy and increase in endoscopic biopsies that the mucosal form is recognized as a much more frequent variant of eosinophilic gastroenteritis. The endoscopic findings are many, they're variable and not really specific. So you could have thickened folds, ulcers, nodularity, whitish specks, which could be consistent with underlying eosinophilic abscesses, then capsule images showing stricture, aphthous ulcers, especially with cow milk protein allergy in infancy. So a large spectrum of endoscopic findings are recognized to occur with eosinophilic disorders. Similarly, the radiologic features are also not very specific. They may merely represent the thickening of the bowel or destruction of a part of some of the layers of the bowel, or strictures which might have developed because of the disease. Some of the signs have been described with the eosinophilic gastroenteritis, and here you can see thickening of the colonic mucosa, and then this aranid limb-like sign, which is similar to the accordion sign reported in inflammatory colitis. Then this is another patient we saw with eosinophilic ascites, long-standing ascites, and then you can see mural stratification of the bowel loops, including the cecum and ascites here. So very, very variable radiological presentations. And then there are site-specific differential diagnoses. Apart from, of course, the differential diagnosis you routinely consider for eosinophilia, for gastritis, Helicobacter pylori, or drugs like NSAIDs and mycophenolate mofetil. For duodenal eosinophilia, must exclude underlying celiac disease or functional dyspepsia, especially the postprandial distress type, which may be associated with eosinophilia. For colonic involvement, one must rule out strong amyloidosis or parasitic infections and cow milk protein allergy. in the relevant. So how to make a positive diagnosis? Very important to read through the pathology reports, because the pathologist may report the eosinophils, but they may not count and they may not mention it as a differential diagnosis. When one finds eosinophilia, one must deworm the patient, look at the clinical setting, look at what else any drugs could have caused eosinophilia. Are there other causes which can explain eosinophilia? Repeat the endoscopy if possible, do systematic biopsies for colon, segmental biopsies as one would do for inflammatory bowel disease. For stomach, use the Sydney protocol. For duodenum, 4 biopsies from the first and the second part, and from esophagus, from all areas of the esophagus. Also rule out other causes, do a stool examination, colon fluid microscopy for protozoa, and serum tests to rule out infection. Pathologists should also look for parasites, spirochetes, and strongyloidosis in the biopsies which are available. Now, once you have excluded these things and you're pretty certain that the underlying diagnosis is of a eosinophilic gastrointestinal disorder, what is the line of management? The first line of therapy is dietary therapy. And what has been seen is that there may not be much role for targeted diet, which is chosen on basis of allergy tests. Rather, 4-food or a 6-food elimination diet could be a good initial therapy. And elemental diet virtually succeeds in most of the patients, although it is difficult to administer. So the approach is, once a diagnosis and exclusion of other causes is done, there's no underlying surgical issue like obstruction or perforation, then dietary therapy should be tried. If there is a response, one could monitor and maintain on some dietary modifications. If there's no response, the second line of therapy is oral steroids. And once these are tapered, there may be a need to have a maintenance therapy. In patients who don't respond, then other therapies are primarily, I would say, experimental, but there is some evidence of benefit with anti-IgE antibody. So what is the natural history of eosinophilic gastroenteritis? So in a median follow-up of 13 years, 42% patients did not have relapse. 20% had a chronic disease, and 37% had a relapsing remitting course. Now, in patients after 1 year after stopping steroids, you can see that around 45% had some form of relapse. Now, we'll briefly also talk about eosinophilic esophagitis, which we are much more likely to encounter in clinical practice. So apart from the secondary causes of eosinophilia in the esophagus, which we have already talked about, the primary eosinophilia could be associated with atopy or may not be associated with atopy, but a small number could be having a syndromic diagnosis like Ehlers-Danlos or some familial form of eosinophilia. Now, the spectrum of clinical presentation is variable with the age. For infants and toddlers, usually it is the feeding dysfunction, which is the presentation. For school going, it is vomiting, abdominal pain, and in adolescents and adults, it is dysphagia and food impaction. So this merely indicates how the spectrum of the disease shifts from inflammatory to fibrostenotic with time. Now, for endoscopic assessment, there is a score, the eosinophilic esophagitis endoscopic reference score, which has major and minor criteria. And the major criteria include edema, fixed rings, exudates, furrows or strictures, and the minor crepe paper esophagus is recognized as one of the criteria. So here you can see that these are fixed kind of rings, also called as trachealization or corrugated appearance of the esophagus. And they may become severe, so much so that even the endoscope may not be passable. So this is how this particular factor is scored. Then you could have exudates. Again, these are white lesions which may occupy variable amount of surface of the esophagus, and the scoring is dependent upon the amount of surface which is involved. Now, there could be furrows, which are vertical lines. You can see here vertical lines. Again, they may have a visible depth or they may not have. But if there is an indentation, it may suggest a more severe kind of involvement. Now, there could be esophageal edema when the usual vascular pattern may not be as well visible or may disappear completely. And crepe paper esophagus, which suggests mucosal fragility with the passage of a scope, and this is not with dilatation, only with passage of scope. If such kind of trauma is seen, then that's a crepe paper esophagus. Other findings could be feline esophagus or the transient esophageal rings, which disappear with distension with the air. So this is one of the findings which can be part of the eosinophilic esophagitis, and then there could be a narrow caliber esophagus when one cannot pass the scope. Certain new findings have also been recognized. So there is a biopsy pull sign where it is difficult to close the biopsy forceps completely, and when an attempt to take a biopsy is made, there is some resistance to taking the biopsy. So this is the pull sign, which has been described as a feature of eosinophilic esophagitis. None of these is very, very specific. Now, the important differential diagnosis is, of course, reflux disease, and eosinophils, especially in the lower esophagus, may be part of reflux disease. But for eosinophilic esophagitis, the eosinophils would involve almost the entire esophagus, including the upper and middle part, and the eosinophil count will be much more, usually more than 15 per high power field. The eotaxin levels are elevated in eosinophilic esophagitis, and the epithelial hyperplasia is much more prominent. So these are some of the features which pathologists may use to differentiate eosinophilic esophagitis and GERD. Now these are just representative images of eosinophilic esophagitis here, a large number of eosinophils and very small number of occasional eosinophils in the gastric, in the reflux disease. Now, coming to allergic testing, although many people perform allergic testing, including skin prick tests and the serum IG testing, but as of today, there is no clear evidence of benefit of this particular approach in management of these patients, because there is no data to suggest that there is any additional benefit of a diet which is based on testing vis-a-vis the standard elimination diet. So treatment includes changes to the diet, and in fact the elemental diet has excellent results for management of eosinophilic esophagitis. Elimination diet is more acceptable for the patient and easier to administer than the elemental diet. Then many people are not really interested in taking diet over long term. So drugs could be the initial therapy of choice. Proton pump inhibitors, there are a subset of patients who respond very well to this. And in fact, earlier, there was a PPI responsive eosinophilia, which was thought to be distinctive from eosinophilic esophagitis, although now it is very well recognized to be part of eosinophilic esophagitis. And of course, the other drugs are the topical steroids. Biologics, some of them have failed trials, but there is some upcoming evidence for some of these drugs. And then dilatation only if it is needed, and it has to be a graded approach because the initial report suggested that there may be an increased risk of perforation. So steroids, topical steroids, budesonide and fluticasone are the drugs which could be used either as form of viscous slurry, suspension, oral disintegrating tablets, or swallowed puffs from the inhalers. Now, systemic steroids, there's just a single randomized trial comparing them to topical steroids, and in fact did not show much additional efficacy, and therefore topical steroids are the standard of care. Now, there are certain additional therapies which have been tested and not really effective: anti-TNFs, anti-IL-5, anti-IgE. But there is some evidence of benefit with the anti-IL-13 and IL-4, and these are the drugs people are looking forward to for treatment of resistant cases. So dilatation is never a standalone therapy, only to tide over the acute symptoms, because the inflammation which incites the fibrosis also has to be treated. So symptomatic improvement is common with dilatation, and pain is very, very common. So almost 3/4 of the patient will have some amount of pain. Follow-up is usually with symptoms, but must also include endoscopy and documentation of histologic response. In the future, there may be an upcoming role for string tests or cytosponge, but as of today, it is endoscopy with biopsies to document histologic remission. So how do you approach these patients? If there is evidence of eosinophilic dysfunction, esophageal dysfunction, and endoscopic findings are either suggestive or consistent, but they may be normal also. There is histology which suggests eosinophilia. Other causes are excluded. If there is a symptomatic stricture, dilatation. If not, then first line of therapy, depending upon patient choice, it could be elimination diet, PPI, or topical steroids. If there is a response, you continue with maintenance therapy. If not, second line therapy. One of these could be the second line therapy. So to summarize, eosinophilic gastrointestinal disorders, although not very common, are increasingly being recognized, and including in India. And there is a report from AIMS about it in patients of GERD. Eosinophilic gastroenteritis may be less common than esophagitis. The diagnosis is of exclusion, must exclude other causes of eosinophilia, and important to consider in patients who are symptomatic. Subset of eosinophilic esophagitis are PPI responsive. Diet and steroids play an important role in therapy. For esophagitis, PPI and topical steroids are additional options, and maintenance therapy would be needed for most of these patients. Thank you for your attention.
Thank you, Dr. Vishal. That was a very, very, very good talk. So we'll be taking some questions now on both the topics. So first, I think Makaria sir very well elaborated the role of biopsy, the orientation of the biopsy in patients with chronic diarrhea, and how significant that is, because sometimes the disease may not be apparent on endoscopy, and biopsy is the essential reason why it is done. But there is increasing amount of data that is coming out on narrowband imaging, celiac disease also from PGI. So I was just wondering what the panelists feel. I mean, Dr. Mallikarjun and Dr. Lakshmikant, what is your opinion on the role of NBI? Are you using it routinely in patients with chronic diarrhea? Hello?
Yeah.
Dr. Mallikarjun? Dr. Lakshmikant?
Hello. Yeah, in St. John's Medical College, we routinely do mainly a white light endoscopy. Rarely in between we are using a narrow band imaging.
Okay.
Not routine.
Okay.
Yeah, same is true here. So white light, basically narrowband, yes, it is coming up. We are using in between patients, maybe even to target the biopsies sometimes. We are using.
Okay. Another thing was, I think there is since small bowel diarrhea is sometimes really difficult to diagnose the etiology. Sometimes you really wonder how much yield can a capsule endoscopy actually provide. I mean, an upper and lower GI endoscopy may provide the yield sometimes, but I think Makaria sir, if you can take that question. I mean, the yield of adding a capsule endoscopy, although the cost can be prohibitive at times, but what do you feel should be done in those situations?
If you have a simple chronic diarrhea, capsule has no role. In fact, there are ASG guidelines that capsule has no role to play. Suppose you're thinking of Crohn's disease and looking at only mucosal form of Crohn's disease, then one might do capsule. But there's a very uncommon indication. Blindly using capsule for chronic diarrhea may not be very fruitful.
Okay. Thank you,
but
sir.
certainly, once in a while, you're a difficult patient. Difficult means you have gone through all the algorithm, and you have not seen small intestine. Then the baby capsule may have some role. And sometimes we find that the multifocal disease of small intestine, which is mainly mucosal form. But the only thing that even if I find that a couple of ulcers in the capsule endoscopy, do I call it Crohn's disease? Okay, I can still say Crohn's disease, But is it diarrhea because of those few ulcers in the small intestine?
Yeah.
Most likely not. Most likely not. Even the small intestine has multiple ulcers on capsule or enteroscopy. Now we are doing spiral endoscopy. We can reach large area of the small intestine, but this may not be the cause of diarrhea. As I said, diarrhea, colon has to be affected. If you're doing colonoscopy is normal, biopsy is normal. So these lesions found in small intestine, there's a disease like Crohn's disease, but that may not be cause of diarrhea. That's the point I want to highlight here.
Agreed, sir. Agreed. Great. Now coming to the eosinophilic gastroenteritis and eosinophilic esophagitis. Now, data from India is largely sparse. Now, there is some amount of data that came from CMC, an old paper on a case series. Then there was another paper that recently published from Science, again a case series. So it's largely been case series and case reports. So question largely becomes, how common is it to see these disorders in practice? What is the data from AIMS, SGPJ? What is the data from the South, Bangalore, Hubli, all of these places? How frequently do you encounter these? So I think Dr. Lakshmikant, you can start.
Yeah, I am from CMC, so we used to see a lot of these the case series which which was earlier in 90s and 2000s. So there was a series from CMC.
From CMC,
so, yeah. So the previously, I think the prevalence was and the incidence was assumed to be low, but I think now it is going up. But I can't see many papers coming out from it. But personally, we are seeing, I think, more and more, probably more appreciation of the disease and more the biopsies that we are taking, and the pathologists also being able to give this. But I can't quote any studies on that.
Okay, like I think, like Sir said, with better biopsies, better correlation, and better relations with the pathologist, I think you were able to establish the diagnosis. Sir, any data from AIMS, any series that you feel? I mean, how many patients?
From Makharia's paper only.
Number of patients.
Yeah.
There's one paper where we looked at patients with the refractory GERD, and I found a 6% of refractory GERD were because of EOE. The point is, you raise very important points, Dr. Caesar, that it's not about what is the incidence and prevalence. Question is, are we looking for it? If you look for a disease, you will find it. If you don't look for a disease, so absence of data, absence of reports does not mean the absence of disease. First point, how many of us are interested in GERD, and how many of us are really interested in academic GERD, doing non-endoscopic academic interest? We have academic interest on endoscopy, but how many have academic interest on pathophysiology of GERD? If you don't have, we'll never find it. And if I don't publish a report, my country will not see this disease ever. Therefore, I think they are not very uncommon. We don't looking for it. And it's good to do those patients who have a GERD, those who have a mild. Again, we pick up a disease when there's a dysphagia, when there's a stricture. But we don't see a disease which stricture means disease has come almost 10 years or 5 years long course. We did not find it much before that, as Dr. Vishal showed all the steps of evolution of the esophageal lesion. So it's good to think of these disorders, and even if there's no report, does not mean they don't occur in our country. We must look for, in the right patient, we must do biopsy and see that if they are, not only biopsy, but tell pathologists also, they will count. Otherwise, they also say, okay, it's normal. You review so why is saying so? Because we have a path conference. All patients who remain undiagnosed by routine histology, routine reporting, we always go back into conference, or we go back to do a MDT, multidisciplinary team, and we find totally diagnosed totally different. So talking to pathologist always helps.
I think Dr. Vishal also mentioned the need to rule out other hypereosinophilic disorders. So I was just wondering, what were these disorders that were actually? I mean, what are the tests that are done routinely to rule out the other hypereosinophilic disorders? If you can elaborate, Dr. Vishal.
Yeah. Hello.
Yeah.
Am I audible?
Yes.
So there are no guidelines as such to really suggest that this is a particular battery of tests which should be employed. But one should certainly, I think, look for peripheral eosinophilia, and especially so when you are considering a diagnosis of eosinophilic gastroenteritis. And there, if you have a significant eosinophilia, then you may end up occasionally recognizing hypereosinophilic syndrome, which can be idiopathic but can also be part of hematological malignancies. And in fact, many people would take a hematologist opinion, or maybe go ahead with a bone marrow in these patients. Apart from that, certainly a stool workup, stool examination, and asking your pathologist also, to look for any parasites. Sometimes strongyloid may be picked up on histology, and in fact, there are now reports of spirochetosis, which have been associated with the eosinophilia. So most people usually would not look for it, but when you know it, then probably it is better that you look for it. Again, drugs, that kind of a history, sometimes we miss out, and occasionally we will find that people who are on NSAIDs. NSAIDs are one drug which are very commonly taken and are also implicated as a cause of eosinophilia, GI eosinophilia. So I think all these things should be there, and it's a contextual setting or a clinical setting which should guide our approach and the tests.
Okay. Thank you. So another thing was the role of allergy testing. You mentioned that the role of allergy testing is still unclear. So question, Raji, becomes: is it really used in practice? Are we doing allergy tests? What is with increasing number of immunologists who are coming in practice, a lot of these allergy tests are actually employed. So Dr. Lakshmikant, if you can actually tell us if you're using it, or if, what is your opinion?
Yeah, I'm not using it actually, but I do get patients who have come with those reports. So that is where the problem is, how to interpret that. So that they have categorized into 3 categories: none, moderate, or severe, or something like that, which has categorized. So
sorry to interrupt, sir. Only 2 minutes are left, sir.
Thank you.
I think Dr. Vikas can guide us something. I can't have much of problem. The interpretation is very difficult, I think.
I think Govind sir has wanted to say something. Yeah, Govind sir.
No, I want to raise other point was, if you permit, this is regarding the role of steroid in eosinophilic disorder. As Dr. Vishal said, that most of the reports are from children, pediatric age group, and therefore all the reports suggest that tropical steroid is fine. But I just putting this point to a question, although we don't have data. There's only one study comparing topical versus systemic, which also has a sample size problem. The point is that somebody comes to me with a dysphagia, and I do endoscopy, find there are ulcers, and they are a kind of stricture formation. And I do biopsy, I find there is a eosinophilic esophagitis. Question that I'm losing my esophagus now. Patient esophagus is now deeply inflamed and now leading to stricture formation. We don't have time. So rather than giving this patient a topical steroid, which I personally have a doubt on its efficacy, will I not use systemic steroid in such a situation where time is a real issue? Because by the time patient with dysphagia, you're always losing your esophagus, and therefore using more robust therapy probably will be the. I would prefer to use, even there's no evidence, but I prefer to use the systemic steroid in situation where we are losing esophagus for severe inflammation. Vishal, any comment on that?
Yeah,
Sir, it's 4:45, sir.
Just
yes,
a last comment.
Yes, sir.
Last comment. Vishal.
I will totally agree with it. The evidence is that topical steroids are definitely equal to, systemic steroids are definitely equal to, topical steroids, and certainly they could be better also. And
but depends on where, what disease state are they actually used in. In fibrostenotic disease, we really don't know what.
Certainly we need to hit hard and hit fast.
Yeah. Okay. Yeah. Thank you so much. Thank you, Vishal sir. Thank you, Govind sir. Thank you, Lakshmikant, Dr. Lakshmikant. Thank you, Dr. Mallikarjun, and thank you to the chairpersons. It was a wonderful discussion. Thank you again. Thank you, Endocon. So we'll see you for the next session. Thank you.
See you. Bye-bye. Thank you, everyone.
Thank you.
Thank you.
Thank you, sir. Thank you.
Thanks. Yes. Sorry.
Yeah, he does not have available. So basically, they can start continuing. While they're starting, he needs it. Not